Yeah, definitely an important subject. And first of all, thank you very much for having me here today. I certainly appreciate the chance to talk about CKD and CKD in marginalized populations, particularly. And so certainly, I think we're all aware that the main driver for CKD overall, but particularly among communities of color, is hypertension and diabetes. So as those rates have gone up, we see a lot more CKD in patients. But I think there has also been a measurement error. Traditionally, folks from Latino backgrounds or other marginalized backgrounds don't have the same access to quality healthcare services. And we are seeing some change there. We are seeing some momentum moving forward. And so folks who may have had CKD present for 15 or 20 years are now being diagnosed. Unfortunately, they're being diagnosed in advanced stages of the disease, but still, it's something that I feel like is some advancement because at least we can try to help. What we want to do is get more people in the door sooner so we can make a bigger difference. Well, I think we want to certainly be aware of those risk factors. So screen folks with those risk factors, hypertension or diabetes being the two principal ones, with two tests, both an EGFR and a urine albumin to creatinine ratio, or UACR. So you need a blood and urine test to really help you with the diagnosis, because they're both very, very important in terms of the prognosis, not just for the kidneys, but for the patient's overall health, particularly cardiovascular health. But I think it's also important to just build a trusting relationship, not just with individual patients, but with communities. So those patients who feel like they don't have a place in the healthcare system, who may have some trepidation about coming in, feel a lot more comfortable about presenting, talking about some of their symptoms. Maybe these symptoms actually they could very well be symptoms of chronic kidney disease, even though that's far from the patient's thought and where they think they may be in terms of disease state. We should recognize on our end that CKD is a prominent part of the differential diagnosis. Sure. I'm very proud of the program Medical Education for the Latino Community. It was founded in 2004, and it takes about 12 students per year who have a background in the Latino community. So they know the community, they're from the community. What they also, very importantly, have a goal to go back and improve the well-being of that community. We give them some special training in UC Irvine School of Medicine beyond their regular medical school training. So they're accepting extra work, including a master's year of their choosing beyond their regular curriculum. And it's been outstanding. We definitely see our graduates now who are free and clear of residency, they are walking the walk. The vast majority, over 80%, are in primarily disadvantaged and primarily Latinx communities and working in a variety of safety net facilities, whether it's a hospital or a clinic, in those communities. And I really see them making a difference. And they're also gaining some leadership positions now with health and human services, in local elected positions. And I see that kind of leadership moving forward, again, to go upstream to address some of those social determinants of health, which result, in the end of the day, in more severe kidney disease for our community. So we actually train our UCI students to become physician activists. So that's a term we have really embraced, and that they embrace as well in their careers. But every physician and every healthcare professional should have some activism in them. So I guess the first thing is know the issues, know those issues that are affecting your patients, that are leading to higher rates of obesity and diabetes, that lead to higher rates of poor health screening and poor access. And then go out and advocate. I think you're a very special, privileged place. That's something we teach here as well when you're a healthcare professional. And people will automatically give you some space to be listened to because of respect and because we have knowledge and we're trusted in the community. So have a voice. Certainly vote. And yeah, really try to advocate. Maybe it's by signing petitions or working with local nonprofit groups. There are ways, even small ways, that may just take a few hours a week, that over time can make a big difference. Right. And that's another deficit that, that lags behind. And I think it's because there has been this history of exclusion in terms of people of color from mainstream healthcare. And so I do see changes. I see folks, working to bring more folks in. And so I think that this is something that all of us have a responsibility towards. Now, a lot of my patients aren't necessarily considering becoming donors, but by having that trusted relationship and establishing that, years before their brother or someone close to them becomes sick and they think about becoming a donor, that's a very incredibly good foundation for having a conversation, an open conversation about the benefits, risks, and some of the challenges and, wonderful things that could happen with donations. So I think that yeah, it all starts with a good relationship with individual patients and with the community at large. And so I would call out not just healthcare professionals, but health systems are really accountable for that.